we go. All right. So thank you, Dr. Cherukuri, so much for joining us. It's a pleasure having you on Zoom Clinic, and the stage is all yours.
Okay, great. So let's jump right into it. So I am an international graduate. I went to American University of Antigua, so one of your neighboring islands there. I was there for about a year and a half, and I finished up in 2011. Right now, I'm currently in private practice neurology for the past 3 years, since 2017. I'm board certified in both neurology and clinical neurophys. I practice basically general neurology. We have a handful of procedures that I do, including EEG, EMG, which is a nerve conduction study basically, and lumbar punctures. I've been married for 8 years. I have 2 kids, ages 6 and 3, and 2 sisters and a brother. And I told my sister I wouldn't embarrass her on this, so I'm going to try not to do that. All right. So that being said, how do I go? There we go. Hi, Charisma. You there? You can talk, Charisma.
My God, I'm here.
Okay. Sorry about that. All right. So my path, basically I'm from New Hartford, New York. It's the smallest town in upstate New York. I went to college out in Albany, which is at Siena College. Like I said, I went to American University of Antigua. I did my 5th semester in Miami afterwards, and basically all my clinicals were done throughout New York State, mostly in Brooklyn and Staten Island, but a few in Utica and then Syracuse. I did my residency in Syracuse at Upstate University Hospital for 4 years, and then I did an additional 5th year there in fellowship in clinical neurophysiology. Like I said before, I'm in private practice as part of a large multi-specialty group. So there's over 60 of us in it with many different specialties. So it makes it very convenient for patients when they come to us. We often refer to each other, and people are happy to have their 4 or 5, even 6 doctors all in the same building. Let's see. So my tips for you guys, on your journey. Worship at the altar of the USMLE. The USMLE is really the biggest thing, I think, when applying for residency. It's what's going to get your foot in the door. If your score is borderline or low, you're not even going to get the interview. If you manage to get the interview, you're basically on equal footing with everyone else. I mean, it's really just about your personality and how well you're going to get along with others at that point. But what I did for the USMLE, I used the first aid and the UWorld question bank. I don't know if you guys have even started looking into this stuff yet, since you're, I think, pretty early on, right? Are you in your first year still?
I think everybody, or I'll speak for us, we're in our 2nd year, so we're getting ready to take the comp and step 1.
Right. Okay. So yeah, I mean, these would even be helpful for your comp exam too, since a lot, I think the comp that they usually, at least ours, was made up of, old board questions for the most part. USMLE step 1 first aid is pretty bare bones. I don't know if any of you looked at it, but it's much more concise, and it's more about like buzzwords and things like that. So you kind of got to supplement it with something else. So UWorld's really helpful for that. It's a huge question bank, and it was very close to simulating the actual exam. So when I went and actually take my exams, I felt like I already done it before, very familiar with the setup and the software, and basically what to do. My next piece of advice would be to visualize. And I think this is hugely important for motivation all the way through med school. I mean, it gets hard to keep studying, late into the night when you have to for exams. And I think just, visualizing your life, in the future as a doctor, having the answers that might save someone's life is really motivating. So that's what I did all the way through. And basically everything I ever visualized, aside from winning the lottery, has come true. So it's definitely something to help with motivation. Don't forget to enjoy the ride. I mean, you're going to meet a lot of people along the way, which you already have, I'm sure, who become lifelong friends and colleagues. So definitely try not to, lose sight of that. Because basically, before you know it, your 20s are over and you're a doctor in your 30s, and you're like, what just happened? I want you to try to have a strong medicine foundation. Many of you will go into internal medicine or family practice where that's all you're going to do. But if you do specialize like I did, having that strong medicine foundation really is helpful, with understanding patients. Because it's not, when you go, like for me, to see a patient in the hospital, it's not just a neurology patient, it is a medicine patient with other medical issues that have them admitted. And a lot of those issues tie into what's going on neurologically with the patient. So really understanding the body, the heart, all the organ systems is very important. So make sure, even if you're going to be a specialist, do as many medicine rotations as you can later on. Um, Stay open to all your specialties when you're rotating. I think that makes it a lot more fun. Honestly, I had no idea what I was going to do up until I was almost applying for residency. Basically, everything I did, I really enjoyed. And when the doctor you're rotating with sees you enjoying it and you're really interested, they take a special interest in you. So, and you want them to do that because then they're going to be more likely to teach you more extensively and really take you under their wing. I'm not saying deceive them, but definitely show an interest. The bored ones, everyone just ignores them. The students who are just bored out of their mind. This next one is let your name become a jingler in their head. This is more with when you go to do your elective rotations. This is later on, before you apply for residency, you'll be able to do electives. I would say do all of your electives in a hospital where you want to go, the one place you want to be. And if you want to do a specialty or not, I mean, try to do electives in what you want to do with those people over and over. That's what I did. I did almost 3 months of neurology type rotations at Upstate in Syracuse, New York. And basically by the end of it, they knew me so well that they ended up just pre-matching me. I don't think that's still a thing anymore, but that really helped me get my foot in the door there. Kind of stepping aside from the medical stuff, make sure at some point along the way, it's kind of hard to do this while you're studying, but make sure you start understanding money because you're going to be getting paid more than most people eventually. And being smart with that money and making it go a long way is very important. You don't want to grind yourself in a clinic setting or hospital setting the rest of your life. It's hard to enjoy it that way. What helps you not have to make it such a grind is if you're managing your money well and growing it properly. And one thing I wish I did in residency when I actually started earning an income was starting a Roth IRA, which is a type of retirement account that grows tax-free. And then at the end, you take it out tax-free. So it's really something that's hugely beneficial for you. So just that's an example, but start looking into this stuff at some point. Let's see. So what is neurology? Neurology is basically where we're taking care of diseases of the nervous system. The nervous system, there's two major divisions, the central nervous system and the peripheral. Central is basically the brain and spinal cord. Peripheral nervous system, you have both your motor and sensory portions, and this is everything outside of the brain and spinal cord. So the nerves, the neuromuscular junction to the muscles, and then the muscles themselves. Sensory portion is basically all the sensory fibers in your hands and feet coming back up through the peripheral nerves, and then of course entering your central nervous system. The enteric nervous system down there is kind of the intermediary between the sympathetic and parasympathetic, and this is found mostly in your GI tract. So your autonomic nervous system, if you look over on the left side here under motor, autonomic nervous system is the part of the nervous system that governs all the automatic activities in your body. So things like your heart rate, your GI tract, your blood pressure, all sorts of things that are automatic that we don't think about. Sympathetic nervous system is the fight or flight system. That's that bottom left one there. So that's fight or flight. So this is when you're scared for an exam and your heart rate goes up and you start sweating. That's that system activating. It's meant to protect us. Like if you see a lion, you don't want your parasympathetic system activating and digesting your food and you yawning and getting sleepy. You want to be able to act appropriately and get away. So that's the system that activates us to save ourselves. Parasympathetic is the opposite. This one is the one that slows you down. You're resting and digesting with this one. So it's important to know about these as a neurologist when you're treating diseases affecting them. So lesion localization, basically in neurology, history and exam are everything. This is not true with other specialties. Take for instance, my wife, she does heart surgery. And in her field, she's handed the answer before she even sees the patient. And it's basically, they're glorified plumbers in my opinion. They just put things back together. They already know the answer. There's no thought involved. I joke, of course, but it's very different from neurology. In neurology, you're given a set of symptoms. And from there, you try to figure out first where the problem is, and then next what the problem is. So I always like to teach people to think from where the neurons begin and where they end. So the pathway is long, but basically, let's take someone with arm weakness, for example. So that weakness, the innervation for your muscles comes from the motor pathway in the brain. So the primary motor cortex and the posterior aspect of the frontal lobe. From there, it passes down through the thalamus, through the brainstem, into your spinal cord, out through a peripheral nerve into your arm, down to the neuromuscular junction that connects that nerve to the muscle fibers, and then of course the muscle itself. So the problem can lie anywhere in that pathway, and that's your job as the neurologist to figure out where it is most likely. After you figure out where the problem is, it comes to what is the problem, of course. So I mean, is it a stroke in the brain? Is it an MS lesion in the brain or the brainstem? Is it a spinal cord lesion? Is it inflammation of the peripheral nerve? Is it something affecting the neuromuscular junction that connects that nerves to the muscle, like myasthenia gravis? Or is it a primary muscle issue, like polymyositis or dermatomyositis? These are all things we have to consider when considering a patient's problem. And then, of course, once you figure out what it is, you treat it. So there's a lot of deductive reasoning involved, hence the little Sherlock Holmes there. So any questions so far before I get into the case here where we kind of demonstrate this line of thought? Okay.
If anybody does have any questions, feel free to unmute yourself or even send it in the chat and we can go ahead and read it from there.
I'm not sure I see the chat. I have to make you guys bigger, I think. I don't want to see me.
It's okay.
All right.
Manage
Read them to me if you see it, okay?
Yeah. Of course. Okay, thank you.
All right. So this is a patient I saw probably in September 2020. He's a 74-year-old man. He came with 3 weeks of weakness and tingling in the legs. So immediately we got to start thinking, where does the problem lie? Don't jump to what, because then you miss stuff. Oh, honey, go back out, okay? I'm teaching people right now. Sorry, that's my daughter. Go back out, okay, honey? I'll be out soon. Okay. So immediately you got to think of where's the problem, not what, but where. So thinking of localization, and feel free to unmute yourself so we can talk here. Weakness in the legs. So we're going to be considering the whole pathway running down to the legs. So give me an idea of what you're thinking. And there's no dumb answers. You guys are starting out. Just give me some ideas of where we can start thinking the problems lie. So
would you
on the screen here? Go ahead.
Look at like the spinothalamic tracts.
So yeah, that's a long tract. So that's still running basically from the brain all the way down to the legs. Mm-hmm. So for example, we have the legs being weak here. Let's trace the nerves up. You guys see my pointer, right?
Yes.
Okay, so we're tracing the motor fibers up and the sensory fibers, and they come right into the spinal canal here. So what would cause both the legs to be weak? What single point of interest can do it? In this case, I would say maybe the lumbar spine, right? This is where the leg fibers join up. So if you have a problem here, like a bulging disc or inflammation, you can make both legs weak with a single area being affected. So it's not always a single spot causing people's problems, though. Let's take, for instance, terrible polyneuropathy, like diabetic neuropathy. If it's bad enough, it can make people weak in their legs. So that would affect just diffusely the nerves here. And typically neuropathy starts in the feet and over time creeps up the legs. And by the time it gets to around the knee, you start seeing it in the hands too. And then they progress from there together up the arms and up the thighs. However, a guy with only a 3-week history of that's a little quick, but not impossible. So you have other subacute neuropathies that are not from diabetes. For instance, I don't know if you've heard of Guillain-Barré syndrome. Guillain-Barré syndrome is an acute to subacute attack on the nerves in the legs by the body that starts often in the feet and has ascending paralysis moving up the legs. In addition to this, there's the chronic form of that, CIDP, that can do it too. So possibly a bad neuropathy affecting the legs, possibly lumbar stenosis or inflammation here in the lumbar spine. What else might we think about in terms of either, spinal cord, brainstem, brain, What else do you think might be a possibility?
Could it be like a pinched nerve?
Yeah, so like pinched nerve in the back, like lumbar stenosis, right? Like also it can be like a thoracic spinal cord lesion, because so far we've only been told that the legs are weak. So that would mean that we're most likely below the cervical spine, because cervical spine is where your arm fibers come out, right? So if cervical spine was affected, the arms would be affected in some way, most likely. So far, all we know is the legs are affected. So it could be nerves down here, lumbar spine, or thoracic spine below the cervical spine. Another more remote possibility that is I've probably only seen once in my 8 years is if you go up, where's a good picture? So here's your brain, right? This is the lateral part, this is the medial part, and then the other half of your brain would be over here. If you look at the homunculus here, this is the visual representation of what parts of your brain control what. The hand regions out here, face and tongue, throat, but over here, the leg part hangs down into this, the falx here between the two brains, the interhemispheric fissure. So this part is your leg. If you have a midline lesion in the brain, like a big tumor, for example, pushing here, and on the one on the opposite side too, you can get bilateral leg weakness and even numbness or tingling. But that's very rare. We don't jump to that. We only look in the brain for leg weakness if we find nothing else elsewhere. So that's initially how we go about figuring out where the problem is. But of course, we need more information because it's a lot of points that could be the problem. So let's move on. Now, so the patient admits his hands have been a bit clumsy with less dexterity recently. It's hard for him to make a fist with the right hand, so there's a little bit more on the right, possibly. He states that back about 4 months prior, he started having some difficulty urinating and had been catheterizing himself. And even 1 to 2 months after that, he started having constipation. So we have this kind of progressive decline that started a few months back, starting with difficulty urinating and then difficulty pooping. And of course, the hands started at some point too. So going back to our picture here, where might we be able to narrow this down now that we know the hands are involved and the urine and the bowels? What are your thoughts?
Could be more to the lumbar region.
So since the hands are involved, let's look at the hand fibers here. So we're following up the arm, and then we come to the neck. So a way we can have both legs and arms affected is if it's a spinal cord lesion in the neck or above. Make sense?
Yes.
Basically, you have legs come all the way up here, go into the spinal cord and follow the track all the way up here into the brain. Since hands are also involved, it's most likely going to be a lesion here in the spinal cord or a bad neuropathy that's spreading quickly. And by that, I mean it's spreading up the legs, spreading up the arms. So you're getting clumsy hands, you're getting clumsy and tingly legs. And if it's bad enough, I suppose even some bowel or bladder changes, although neuropathies typically don't do that. So we would think either bad neuropathy, less likely given the bowel and bladder stuff, assuming it's related, of course, or cervical cord lesion or a problem in the brain. So let's go forward and find out more about him. So he was diagnosed with bladder cancer 1 month ago, which is of course important, but it doesn't necessarily mean it's related, but it's something we keep in mind given his bladder symptoms. He has high blood pressure, high cholesterol, enlarged prostate, and history of TIA. He has a history of a cataract extraction and gallbladder removal. He's on a few medications. You always got to wonder if medications could be having side effects on the body. Tamsulosin is used to relax the prostate and allow urine flow. This is a blood pressure medication. And this is a cholesterol medication. Cholesterol meds in the statin class are infamous for causing myalgias and muscle weakness and sometimes even muscle necrosis. But in this case, he has sensory findings as well, and he's having these bowel and bladder symptoms. So I'm not so certain that this would be relevant here, but we keep it in mind. In regard to the family history of some heart disease, not really pertinent to this case. He used to drink heavily earlier on, and that's always important to know, but he claims he stopped 20 years prior. Alcohol can cause direct toxicity to the brain, the spinal cord, and even the nerves. So people tend to get terrible neuropathies after years and years of drinking. But again, this guy stopped a while ago, and his problem is very much more recent than that. So probably, even if it did damage in the past, is probably not the main driver of what's going on now. He claims no drug use, no smoking. Drugs are important, especially in younger people, because they're going to cause all sorts of problems like strokes and infective endocarditis and heart attacks, all sorts of stuff it can do. Like when you use cocaine and heroin. Heroin can do severe damage to the spinal cord and brain. So moving forward, review systems is where we basically just kind of comb through the rest of the systems and see if there's any other symptoms that could be helpful. This is usually pretty brief and you're a specialist. You're usually not dipping into that area unless it might be helpful, but usually not much there. So now onto the neurological exam, the next most important part. So his mental status, you start there, you ask, alertness, ANO times 3 is alert and orient times 3. So alertness is basically how awake are they? Are they fully awake and talking to you? That's alert. If they're a little sleepy, that's lethargic. Deeper sleepiness could be like obtunded, stupor, or even a coma if they're completely unresponsive to any external stimuli. Orientation, we usually ask, what's the month, what's the year, what city are you in, what kind of place are you in? Who's the president, that kind of stuff. And you can get as elaborate with that as if you want, if mental status is a major part. But since in this case it's not really in question, we kind of limit it. His speech is clear and fluent. There's no slurred speech. There's no problems with content of speech like aphasia from stroke, for example. He follows commands perfectly well. So you understand spoken language, which is of course important to know. Cranial nerves are the peripheral nerves that come out of the brain. These they govern all the different functions in the head, basically. So pupils equally round and reactive to light, always good to know. Extraocular muscles are intact in all directions. Light touch is intact in the V1, 2, and 3 areas of the face bilaterally. Did you guys cover cranial nerves at all yet?
Yes.
Okay, so this isn't completely foreign then. All right, so face is symmetric at rest and with activation. I usually don't tell people to smile only because the emotional aspect of smiling can correct a facial droop that would otherwise be there if you just told them to grit their teeth. So yeah, don't ask for a smile, ask them to grit their teeth. There's also strong and symmetric eye closure and brow lift. So this is important in a guy like this because if we were dealing with something like Guillain-Barré syndrome, oftentimes that can simultaneously affect facial function. So like facial movements. I had a guy recently, he was like 20, I think maybe 25, 26, who came in with weakness in the arms and legs, and his face was basically as flat as can be. He couldn't show any emotion because all of his facial muscles were paralyzed. So people just thought he was grumpy. But when I saw him, clearly he couldn't move his face. So always important to keep this stuff in mind. Finger rub was heard equally on both sides. The hearing's intact. Soft palate rises symmetrically in the back, and his tongue protrudes. There's no fasciculations or atrophy, which is another important thing in a guy like this because let's say ALS was a problem here. You might see it affecting the tongue with some atrophy or fasciculations. But of course, if he's only had problems for the last couple of months, that'd probably be less likely. We'd probably hear that he's been having problems for longer, but it's not impossible. Also, ALS doesn't affect sensory function, so he probably wouldn't have numbness or tingling like he's saying. So that makes it less likely, unless he has two things superimposed, which happens sometimes, both ALS and neuropathy, for example. But anyway, moving forward. So motor examination. You check the tone. That's just by passively moving the arms and legs when they're not activated. In his case, he had normal tone, but he had wasting of the interossei muscles of the hands. So here's an example of what it can look like. So normally you have a nice full muscle here for your first dorsal interosseous muscle between the thumb and index finger. And also usually these aren't caving in between each finger, but when it's advanced, they can start to look like a bony skeleton hand. And usually what this means is either the ulnar nerve is being pinched and destroyed, usually at the elbow where it passes through the cubital tunnel, or it could be cervical stenosis in the neck affecting the C8 nerve root coming out because these muscles are also C8 innervated. So usually it means cervical spine or ulnar nerve is affected. So we keep that in mind. That's something always look for with weakness. In terms of his arms, he has mild weakness proximally, much more weak at the tricep muscle and much more weak even in the hands. So you have this kind of gradient in his case where he's not as weak proximally, but more so in the hands. The legs, there's mild weakness, but it's there. Sensory exam, he has the pin is dull in the feet and arms, all the way up through his body, up to the base of his neck where it suddenly becomes sharp. So this is what's referred to as a pinprick sensory level. And when you see the pin like this dull in the legs and arms all the way up through the body to the neck, it means that something's going on in the neck, because that's why basically you have sensory loss up until there. If there's a problem there, you have a problem from the neck down. If you have a problem in your thoracic spine, you'll have a problem from the thoracic spine down. Lumbar spine, same thing. So pinprick sensory levels can really make it easy to see where the problem lies. So this is very suggestive of a cervical spine problem. Reflexes, we have heightened reflex. Did you guys learn about upper motor neuron and lower motor neuron signs yet?
Yes.
Okay, so classic upper motor neuron signs here. We have 3+ bicep, tricep, and brachioradialis reflexes. So he's hyperreflexic in the arms and also in the legs with the patella and ankle jerk. There were bilateral Babinski signs with stroking the bottom of the foot, and also even triple flexion signs, which I'm not sure if you guys actually learned or not. I didn't learn that one until I was in residency. But basically, it's just a more severe form of the Babinski. Babinski sign, you stroke the bottom of the foot and the toes, big toe goes upward and all the other toes fan out. With a triple flexion, the whole leg pulls away and it looks like a voluntary movement. Basically, the leg flexes at the hip, the knee, and dorsiflexes at the ankle. So when you get that, that's a very obvious one, but sometimes people will confuse this with this voluntary pulling away because it's uncomfortable that they're being stroked on the bottom of the foot. Even people who are otherwise comatose or we're thinking is brain dead, we go in and stroke the bottom of the foot and the leg pulls away. Suddenly the family thinks they're alive when in fact it's just a spinal reflex. So it's the Babinski, spinal reflex, all these things are not mediated by the brain. So when they're present, you got to be careful how you interpret it. It's not like a sign of brain function, but rather it could just be a reflex. So going down here now, there was no ankle clonus, but that is an upper motor neuron sign when that's present. And basically what you do there is you dorsiflex the foot upward at the ankle. And if it starts jumping and kind of like tapping against your hand, that's an upper motor neuron sign. Hoffman sign is another upper motor neuron sign that's seen in the hands when you basically kind of pinch it's kind of hard to, I don't want to unshare the screen and screw this up, but I can show you at the end if you're interested. But basically it's a hyperreflexic sign in the arms. So we have some hyperreflexia signs and some that are absent, which is sometimes the case. Not everyone's body is going to have every single sign. Then onto the cerebellar signs, there's no ataxia during finger to nose testing, heel to shin testing. I didn't write it on here, but his gait was wide base. So his balance was impaired. People with impaired balance often will have a wider stance and sometimes even take on a waddling quality when they walk. So what test would you guys consider ordering? MRI, a nerve study, EEG, lumbar puncture, or maybe just a massage? What do you think?
Probably you want to see MRI, Rachel said.
What do you want MRI?
Go ahead, Rachel.
Let's see, spine and lumbar.
Okay, yeah. So usually when, so in this case, for example, I was suspicious of C-spine. So I would start right there, but sometimes we're not sure and we end up just MRIing the entire spine because let's just say the patient appears weak in the legs or arms and they're confused. So I can't get a great history. We end up kind of doing a shotgun approach and just kind of MRIing everything and throwing all sorts of blood work at them. So yeah, sometimes we can MRI more than one at once, but if we did that on every single person, that's a lot of healthcare dollars being wasted. And if everyone did this, the system just can't support it. So in this case, just given the hand and arm involvement, as well as the bowel and bladder involvement, bowel and bladder involvement in this way is with retention, like retention of stool, retention of urine, is often a spinal cord sign. So I would probably go right to the cervical spine first. And if that was negative, then expand the search out into the thoracic spine and lumbar spine and maybe even the brain. And of course, we'd probably want to get a nerve study at that point too. But if I wanted to try to get the most bang for my buck immediately, I would start right with the neck.
So you would say you would start at the C-spine because of the lower symptoms, not because of the hands?
Well, because the hands are also involved, that would immediately put me to the cervical spine or above.
Okay.
Yeah, because you imagine all your motor fibers coming out from your brain and going down through your spinal cord. If you have the first stop when you get into your spinal cord and your neck is the arms. They veer out through the spinal nerves there to the arms, and then they continue onward down the spinal cord to the legs. So in order to get both, you're going to have to do, there's got to be a bottleneck up here in the neck. So that's where we would look first. So in this case, I did the MRI and this is what I saw. So to orient you, this is anterior. This is the anterior neck. This is the posterior neck going into the shoulders. This gray stripe here, this is the spinal cord. This is spinal fluid, all this white stuff here. And normally there's a thick rim of spinal fluid all the way up through here, up to the brain. In this case, as you can see, it disappeared here. So you have bulging discs, you have hypertrophic ligaments here, but basically it's so narrow that this guy's spinal cord is now getting crushed. And oftentimes we'll see actually within the spinal cord, there'll be some light, like a white signal in here indicating damage. But in this case, it just wasn't there, which doesn't change anything. He has all the symptoms that can be explained by this lesion alone. And so I would stop my search there. And what I did, I called the surgeon and he had surgery. I just haven't been able to follow up with him. So I don't know what happened to him in the end, but I'm assuming he's better than he was before anyway. So yeah, that's basically the thought process we go through in neurology with working people up. It's always, where's the problem first? And then what's the problem? So in this case, where the problem is, I concluded it was most likely in the neck, given the hand and leg involvement and the type of bowel and bladder changes we saw. And then of course we MRI'd and we found out what the problem is, which is spinal cord compression. And then of course we know how to treat it, which is decompression of the spinal cord. So they usually, they can go in anteriorly here and decompress. They can go posteriorly and do a laminectomy. There's a few ways they can do it, but yeah, that's basically how we do it. So, all right. So questions on anything that I talked about, or questions in general about, the journey of medicine or musings about life, anything?
Can you pull up your slide when you were talking about how to assess the patient? There was something on there I wanted to ask a question about, but I don't remember what it is.
How to assess the patient.
I can't
So
remember.
before the actual presentation, right? You're talking about back in the lesion localization part?
Symptoms.
Hold on, let me share my screen again.
I should have written it down, sorry. I think it was to do with his hands.
So let's go back there then.
Yeah.
Was it this part about the clumsiness in the hands with less dexterity?
No, it was,
For the picture of the hand?
No. Hold on, go back one. What is finger rub heard equally bilaterally?
So that's just checking hearing. Basically, it's a very crude way to check it. I mean, just like when we check visual fields by wiggling our fingers in someone's vision, it's a very crude way and inexact, but you can catch major deficits. So, I mean, even if I did the finger rub, I literally just rub your fingers against each other by their ear. And if they can hear it, you say, okay, that's pretty good, because it's pretty quiet.
Okay.
But let's just say if you didn't hear it, I would make note of it. It more than likely wouldn't matter in this case. But if I saw that along with other maybe cranial nerve signs, like the soft palate wasn't rising properly, or the tongue tongue deviated to one side, I might say, okay, maybe there's a problem in the brainstem that's contributing here, and that would change my differential.
And then the next slide.
Mm-hmm.
Can you pull the next slide? Just No, okay. No, that was it. Yeah.
Okay.
Doc, I have a question. So for the MRI of the C-spine, did you get any like clinical indications of maybe that might be mets from the bladder cancer or something like that? Like, was
So
there a
if
biopsy
Yeah,
from
so if it was mets from the bladder cancer, we would see with contrast that they were lighting up. Usually they light up. In this case, though, it just looks like strictly just bony disease and disc degeneration that kind of came on over time. But yeah, of course, with the history of a recently diagnosed cancer, that's what we're looking for. So if this guy didn't have a cancer history, I usually would just get the MRI without contrast. But since he did have it, I did get it with contrast. It's just not shown here.
Okay, so it would just be like blotchy, I guess.
So when you have a contrast enhancing lesion, usually it shows up very bright. So it's almost like a white color.
Okay, thank you.
Yeah, no problem.
I had one question, just regarding like your medical journey. Did you, I don't know if you had notated, but did you ever do a fellowship post residency?
Yeah, I did. Let's say, yeah, I did fellowship
Okay.
between 2016 and 2017 in clinical neurophysiology, and basically what that is basically learning to do EMG and interpreting it and EEG interpretation.
Okay.
That was 1 year.
Okay. And do you find like you use that a lot, specifically like in your practice? Like even, so I'm just curious, like in your practice, is it specific to those type of cases, or do you see all sorts of neurodegenerative diseases and such?
So, and with this fellowship, this is really one that's necessary for anyone practicing general neurology because you're going to use it every day. So I do EMGs every day. I read EEGs every day. It's what allows me to be a better general neurologist. Some people don't do this and still go into general neurology, and they rely strictly on whatever training they got in the EMG and EEG areas from their residency, but that could be pretty limited. Doing the extra year really allows you to focus on it and develop those skills even more. So yeah, I use them frequently in all my patients because it's really skills for a general neurologist.
Thank you.
I have a question. So earlier you were talking about what's the first course of action when you're trying to diagnose what the person has. But you gave the options of MRI and all the other things we could do. But just because based off of the HPI and knowing that this person has had a TIA, regardless of if they don't have any dysarthria or anything, shouldn't you do a CT first? Just because of the cheaper aspect also, but then go further on?
You mean like a CT of the neck first?
The CT of the head, like just to see if there's like any other.
So
like
you're talking about brain imaging or neck imaging?
Brain, just because it could also have been, since it is, if we go back the homunculus, couldn't it have also been, what's the word? Yeah, so in the middle, the paracentral lobule, couldn't it have also been affecting the paracentral lobule? With the legs being affected at first when we discovered that.
So the way, so basically on examination, the exam helps here. I mean, yes, technically it could be a brain lesion causing a problem, but in this case, you have the wasting of the hands, you have the hyperreflexia bilaterally, and bilateral involvement. So it's hard to get bilateral symptoms like this that are progressive in nature from a brain lesion, just because of how the brain is laid out. I mean, if you look right here, you have the hand over here, the leg over here, and then it's mirrored on the other side, of course, leg and hand. It'd be hard to get a lesion that's progressively making both of these worse. It could happen out here, but it'd be nearly impossible. I've never seen anything like that. Also, but they do converge down here in the brainstem. Technically, you can have a brainstem something down here, possibly causing it.
Like a pyramidal lesion?
I'm sorry?
Like a pyramidal lesion?
Exactly, the pyramidal tract, exactly. But so for instance, if I didn't find anything in the neck, then I would go to the brain. That'd be the next step, as well as doing an EMG of the arms and legs and probably even a lumbar puncture.
Gotcha.
But Sometimes people do shotgun it and just do cervical and brain MRI, but that's usually what internal medicine doctors do without a firm understanding of the central nervous system. I go to where the money is. The smart money's going to say it's going to be right here in the neck based on everything he had. But if I was wrong, which is sometimes the case. So in this case, let's just say the neck was completely normal. What else could be wrong with this guy? He has upper motor neuron signs.
Yeah.
So you worry about spinal cord and brain still. But if let's say we do the MRI of the brain, that's also negative. What are we thinking now? Well, what else can affect the central nervous system without leaving any kind of evidence in the brain or spine? And this might be a tougher one for you guys, so I'll just say it. ALS. So ALS can have.
I was gonna think of ALS in the beginning, but when you said there's no fasciculation, that would mean there's no lower motor neuron in play. But doesn't ALS do both upper and lower?
It does do upper both. So there's variants too. So classic ALS will have a combination of both upper and lower motor neuron signs. There'll be progressive weakness without sensory involvement. Sensory involvement can be seen sometimes if they have something else superimposed on it, which of course makes it very tricky. My first ALS diagnosis in my clinic was a man who had severe neuropathy from his diabetes, but he also had progressive motor deterioration with fasciculations. And so we concluded that he most likely had a bad neuropathy superimposed on his ALS. So yeah, if I go looking at the neck because I'm certain it's going to be the case and then it's not there, I'm immediately getting an EMG because I'm looking for ALS at that point, especially if it's a slow deterioration, which is very characteristic. The other variants of ALS can also be a little confusing too. You can have the entirely upper motor neuron variant with barely any lower motor neuron signs. And you also have the other half of the spectrum where it's almost all lower motor neuron with no upper motor neuron. That's the primary muscular atrophy, or no, progressive muscular atrophy, PMA. And I think the upper motor, what was that one called? That was, I think primary lateral sclerosis, I think it's PLS. So yeah, I just like to be as cost effective with dollars as possible and put patient through less rigorous testing if I can. But if we're in a hurry and they're deteriorating quick, we're going to do a shotgun approach. We're going to do the neck, we're going to do the brain, we're going to order the EMG, maybe even the lumbar puncture all at once. One note about lumbar punctures though, you don't want to do them with a space occupying lesion in the brain, because if you have a high pressure in the skull from like a tumor, for example, and that high pressure is feeding all the way down here through the spinal cord, it's all one pressure. If you go down here now, stick a needle in, and suddenly there's a pressure gradient because you're relieving the pressure down here, guess where the high pressure in the brain goes? It goes downward. And so you can herniate their brain. So that's just a side note, just another fun fact. But yeah, your point's taken that brain could be the thing, but could be the place. But I would always start where the most likely place it could be, which would be the neck in this case, all things considered.
Okay,
yeah, these hands are a huge telltale sign in someone coming to you with leg weakness. If you see this, immediately think neck or ALS. ALS causes these hands too.
Gotcha. Thank you.
Yep.
I had one question also. I was just wondering what was your main reasoning for going into private practice? Just out of curiosity.
Yeah, so the main difference between private practice and like university setting or hospital setting, university, I had no interest in research. I did the bare minimum during my residency because I just didn't have that interest. Working for a hospital that's not academic, so you're at a private, you're at just a community hospital or something, is fine, but you're going to be working you're not the boss of yourself. And I did briefly go work for the local hospital where I am for about 2 months until they pissed me off. And basically, you're going to have people who are above you who aren't even doctors. You'll have business people. You'll have nurses who got promoted up the chain. And these people, they can be difficult to work with sometimes. So if you're the type who has trouble with having oversight and people kind of dictating your schedule and when you take time off, et cetera, that's probably not going to be the place you want to be. Now, private practice, of course, I'm my own boss, but when you're in a multi-specialty practice ran by doctors, there are going to be some compromises you have to make. So in my group, we have over 60 people. We have a or we run ourselves. We have a board of people who run it, and they're all doctors. And we do have some business types in there to help us run it because doctors don't know everything. But so there are going to be compromises like group rules that you can't violate. For instance, I can't have medical students from non-affiliated schools come to see me, even if I know them personally. I can't have my wife, who's a PA, come work for me because they don't want spouses working together, because I guess there was some problems in the past. So you're not going to be 100% the boss of yourself, but it's a compromise, and it was one I was willing to make.
Okay,
I
thank
have
you.
a quick question.
Yeah.
Neurology online, do you find that the future neurology, there will be a greater presence of doctors online?
So during the pandemic, we really tested this idea and really started seeing a lot of people online. But the thing with neurology is I couldn't see a single new patient online because the hands-on examination is so important most of the time. I mean, people who come with migraines, it's going to be less important. Of course, if someone with migraines comes to you and you see that they're weak on one side, you're not going to catch that in an online examination, right? So, I mean, it's very important for us to put our hands on people because the exam can really change what we're going to do. The typical migraine patient that comes to me, they're all going to have a normal examination. And if their history is just nothing with any red flags in it, we don't need to do any imaging. But if I examine them, and like I said, if they have like weakness on one side or some cranial nerve abnormalities, I'm looking for a brain tumor. So really in neurology, online is not very feasible. I mean, sometimes hospitals are stuck doing that though, for instance, like a remote stroke doctor, because they don't have anyone otherwise. So in that situation, it's better than nothing, but it's not preferable.
Yeah, I was curious because we have, I think it's AMO that does a whole bunch of rotations right now online. And I wondered if neurology would be one of them, I guess.
Yeah, I wouldn't recommend trying to do an online rotation for neurology. If you're at all interested in it, I would definitely try to be there and get as much hands-on experience as possible, because a lot of the confidence of being a neurologist comes from trusting your own examination and what you're seeing. So if you don't trust your ability to elicit reflexes, how are you going to recognize hyperreflexia or any of these other things? Someone who has weakness on examination, if you've examined hundreds or thousands of patients like I have, you can figure out which ones are the fakers and which ones are real. And all this comes from hands-on. So I would definitely try to do hands-on stuff if you can. They're offering you online rotations?
Yeah, it's through, I can't remember what it's called, AMO, but it's basically rotations where you can sign up, pay a huge fee, but you get to go and do like an online rotation to see if you like the area.
Right. Yeah. I mean, that's actually probably fine for a lot of other specialties, or non-specialized things. But yeah, I think neurology, you're really going to want to get in there and get your hands on people.
I had a question. So, I know you had said something about getting a lumbar puncture. Would that support your diagnosis of GBS?
Yeah, so if you're suspecting Guillain-Barré syndrome, and usually they have things like ascending weakness and tingling in the feet, going up the legs into the hands. Facial paralysis is very common. Yeah, you'd have to do the lumbar puncture in that case to support your diagnosis. So the classic thing. Does anyone know what you classically see on the lumbar puncture for Guillain-Barré? So it's albuminocytologic dissociation, which means that there's an elevated protein with other parameters being normal. So there's no white blood cell count, there's no change in the glucose, it's just protein. And this is thought to be the case because you're usually checking after. So typically GBS is triggered by some kind of infection or illness. So classically, it's like a Campylobacter infection in the gut, but it could really be anything. It can come after a flu shot. It can come after some other upper respiratory thing, but it's usually weeks later. So the thought is that the protein is still elevated, whereas any white cell count that might have been there before has gone away. And this is in contrast to other diseases of the central or peripheral nervous system, where you might have an elevated, white blood cell count, elevated protein, and a change in the glucose.
Okay, thank you.
Yep.
Do we have any more questions? Feel free to unmute yourself or even shoot it in the chat and we can read it out loud.
I guess I have one last question. Regarding like your rotations, how did you feel like working with your preceptors and such? Like, did you feel like you had room to be able to have hands-on, like one-on-one with the preceptors, even if it's like the neuro rotation?
Yeah, absolutely. Again, I think the more interest you show when you're on rotations, the more they're going to want to teach you, because imagine you being the doctor and then you have the students or residents under you, well, students who are just not interested. You're not going to even bother talking to that person. So I found that the more interested I acted, the more I acted like I was going to go into that field they're teaching, they really took a special interest.
Okay.
I actually had a question too. The closer we get to like being or taking step and like stuff like that, like I've just been looking more and more into like rotations and things like that. And you sometimes hear from students who are uppers or who are also IMGs that some doctors kind of have this bias against IMGs. Did you feel that at any point?
I was definitely paranoid about that all along, especially when I got a lot of my interviews that were among other, American grad students. I really felt like, I think I was more paranoid than anything. I think the places where you rotate, they're used to you guys already being there. So I don't think there's an actual bias because they've already seen hundreds of you before. So no, I think it was more of a paranoia on my part than actual bias against me.
Okay. How did you deal with that paranoia?
What's that?
How did you work through that paranoia? Because I feel like...
Oh, I tried to be the best.
Okay.
Yeah, I would try to be the best in my med school, in my class. I tried to be the best in the rotations, just really really tried to shine, especially when I went to do all of my electives in neurology at the place I wanted to be.
Okay. And then how did you, so during your initial rotations before you did your electives, how did you make yourself stand out? Because like you said, they see hundreds of us, thousands of us like all the time. So how did you get them to catch your eye or vice versa?
Well, trying to answer as many questions as possible. When you're assigned a patient, knowing everything about the patient and, just I think a lot of the challenge early on was trying to integrate all this information, because not only are you talking to the patient, examining them, you're also integrating in their labs, their consultations. It's a lot to put together at first. And I feel like when I was in my first year of medicine internship, that was a big challenge for me. So I felt like I was like just kind of treading water there. But as you get used to it and move on, like later in that year, I felt like I was like really on top of things and dominating. So, I mean, this is going to, come as you go along. You're going to gain more confidence, be able to integrate more information. And the better you're able to do that, the more you're going to stand out to your preceptors. If you're the quiet mouse on the wall, you're not going to stand out. It's going to be hard to get letters of recommendation.
If you could go back in time and redo your rotations, knowing what you know now, is there anything that you would change or do differently?
Studying more for the rotation I'm on, as opposed to going out and getting drunk in New York City.
That's fair.
That would have saved me a lot of work when it came to studying for my boards. So when I had to study for my boards, I really had to go back through all that material again and really learn it. Whereas if I just learned it to begin with, it would have been a lot better. Now, that being said, when I was on the island, I did nothing but have my face in a book. I literally didn't enjoy the island. I didn't do anything. But New York City there's too much temptation. So be careful where you go.
Okay. And then I had another question. In terms of the order of the rotations that you did, like internal first, or like the order of the specialties that you went through, is there any specific order that you would you change your order, or what was your order? What's to take into consideration when you're looking?
So internal medicine is something that's going to be a foundation for most of your specialties. I mean, if you do ophthalmology, you're very limited use of internal medicine, but most other specialties are based off of internal medicine. So if you can at all, and you have a choice in it, get internal medicine or family medicine first, because that'll serve you well going into cardiology, GI, these other rotations where they're all medicine based.
Okay.
Even neurology, you use a lot of medicine when you're managing your own service on the floor. In my clinic, I don't use a lot of it, but really when you're in residency, if you're a neurology residency, or even if you're like orthopedics, other things like that, you're managing people's other problems too at the same time. So, and most of residency is inpatient medicine, not outpatient. I think most of them are probably skewed 80% inpatient, 20% outpatient.
And then did you leave your neurology rotation till the end?
I had my first neurology rotation probably in the middle, only because it was hard for us. I didn't even get medicine in the beginning. I had like psych, which, you know, how's that going to help me going forward? But my neurology rotation was in the middle, and then I did all my electives in the end. There were like 2 or 3 months where it was just, I was in their face constantly. And again, I recommend anyone do that. If you're going to do your electives, do them all in the one place and just keep your face in their face. Not in an annoying way, but like, you know, becoming like part of the team. Like they'd expect nothing else but for you to go there, you know.
So just to clarify, because I don't know if I'm mistaken, but so you did your elective as neurology, yes?
Mm-hmm.
And then you did it multiple times, like you did that same elective multiple times at the same place.
Well, so I didn't do the exact, I did like, so when I went to upstate, I did general neuro, then I did neuro ICU, and then I did, I think, neuro stroke. So it was all in the same pool of doctors, and they all got to know me well.
Okay.
Yeah.
Okay.
Yeah.
Perfect.
Do you have any other questions?
No.
Does anybody have any other questions? All right. I don't think we have any more questions for you.
All
We're
right.
going to say thank you so much.
you.
As IMGs, like we really, really appreciate this and you taking time
Yeah.
to talk to us, because just the advice that you're going to give us is so unique and relatable to our experience. So we just want to say a huge thank you.
Yeah. No, thank you so much. And then especially taking time out of your Saturday. Thank you again.
Yeah, it's no problem. All right. I wish you guys all the luck in the world, and maybe I'll see you out here in the Utica area.
Thank you.
Thank you.
Bye.
Take care. Bye.